So this morning's session is going to be on left heart catheterization, and we're going to start with the indications for the left heart cath. Why should you do a left heart catheterization on someone? So these are some of the more common indications, the reason for doing a catheterization. Acute myocardial infarction. So someone with a heart attack. Um, you might want to do a catheterization because you want to identify the blood vessel that's occluded so you can intervene. Okay, you might be able to put a stent in. Okay, so someone who presents with an acute myocardial infarction, what we do, we have teams on standby that would take that patient immediately to the catheterization lab, and we would do a left heart cath, identify the blood vessel that is responsible for the acute heart attack, and then intervene, putting in a stent. Uh, and we do this very quickly because what we talk about, time is muscle. So if the patients have an acute heart attack, acute myocardial infarction, the blood vessel is occluded, and because the blood vessel is occluded, the heart muscle downstream is gonna be devoid of blood flow, and that heart muscle dies. So you have a limited time interval in which to intervene in order to reduce heart damage, the death of the heart muscle. Because the more heart muscle dies, the worse the prognosis. So there's a rush to do this procedure. And most institutions who that do this procedure, we talk about a door to balloon time, or a door to stent time, and that should be 90 minutes or less. So that is our acute myocardial infarction. Now, unstable angina, if you have the patient on medications, that is, they have blockage of the blood vessel around the heart, they are having chest pains or some chest discomfort. Uh, the patient may have, you know, a burning discomfort. They may have a tightness of pressure. A lot of patients who have, a lot of patients who have uh, blockages not going to give you typical symptoms as a sharp chest pain. And when you ask a lot of patients if they're having chest pain, they tell you no, because what they're having is a tightness of pressure, a burning, some type of, some type of discomfort, not the classic pain. So, um, just give me 1 second. So they're not going to give you the typical a history of typical chest pain. So if you have those patients who have blockages and they usually get chest pain, or they get chest pain, chest pain that's increasing intensity, increasing with less activity, and occurring more frequently, that's what we call unstable angina. And you might want to take those patients to the cath lab, because it suggests that the blockage is getting more significant, and may lead to an acute myocardial infarction, acute heart attack. So, and then patients with what we call chronic stable angina. So angina is when you have a blockage of the blood vessel around the heart, and you know the stable angina is one where if you do any activity, then you get discomfort, tightness, burning, pressure. And then the unstable angina is if the discomfort is occurring more frequent, if it occurs with less activity, and your usual um, maneuvers to relieve the pain is not working. So that's the unstable angina. And then chronic stable angina usually occurs with a fixed amount of activity and is sort of predictable. Then a big indication is stress test. So if someone is having some chest discomfort, uh, and you do a stress test, and if the stress test is positive, so when we say a stress test is positive, they may have significant ST7 depression, or they may develop significant, or they may develop chest pain or chest discomfort with exercise. Okay, so an abnormal stress test, and we have different type of stress tests. We have regular stress tests without any imaging. We have stress echo, where uh, we do echocardiography, or you may have a nuclear stress test. These are different type of stress tests. Ventricular arrhythmia. So if someone is having, say, ventricular tachycardia, one of the most common cause of ventricular tachycardia is obstruction of the coronary vessels, blockage. So that patient may need to go on to a cardiac catheterization. Um, Sudden cardiac death. So someone who you know have sudden cardiac death, they essentially die in the field and then they're resuscitated. A lot of those patients also have significant obstructive coronary vessels. Patient with left ventricular systolic dysfunction, a large group of these patients do have uh, obstructive coronary artery disease, and you might want to evaluate these patients as such. Um, Valvular heart disease. So, patients have aortic stenosis, mitral stenosis, significant mitral regurgitation, aortic regurgitation. You do your catheterization, and if these are surgical patients, the patients need to go to surgery to fix the valve. You'll do a catheterization, not necessarily to see how severe the valvular disease is, but to look at the coronary vessels, because if you're going to take these patients to surgery to fix the valve, you're already in the chest, you're already doing a procedure on the heart, so you just fix the occluded blood vessel at the same time. So it is customary, if the patient is over age 40 and they have significant valvular disease, going to surgery, we would do coronary, a cardiac catheterization, an angiogram to look at the blood vessels around the heart. And then congenital heart disease, if these patients are going to surgery, you need to know what the congenital lesion looks like, so you can plan your surgery. And then you might, if the patient have a, a prostatic heart valve, you in evaluating the prostatic heart valve, sometimes you might want to do a left heart catheterization. So these are some of the most common indications for doing a left heart catheterization. We went over right heart cath and we look at those indications. So let's so again, our approach to a left heart catheterization, we can do vascular access. We can get to the left heart, we can get to our coronary vessels by, and the two most common procedures right now is going through the wrist, where we go through the radial artery, or we can go through the groin, where we go through the femoral artery. So if we go through the wrist, okay, we cannulate the radial artery, and then our catheter will travel through that vessel straight up to the harm vessels, and um, we would enter the right subclavian, then the right subclavian would enter the aorta, and you want to position your catheter this way, because and we'll show you in more detail. Because remember that the coronary vessels comes off the aortic cusp, The right coronary artery comes off the right coronary cusp. The left main coronary artery comes from the left coronary cusp. So, okay, so from our right radial approach, okay, you go through the radial artery, the brachial artery, straight up to the right subclavian and into the aorta, and then you can cannulate your coronary vessels. If you're going to do it femorally, then you go through the femoral artery. Femoral artery will give rise to the iliac, the external iliac, then you have the common iliac, then that leads into your aorta, and you come straight up the aorta, and you have to go now to the aortic arch. So you have to go over the arch and then go to your ascending aorta, and then get to the cusp where the blood vessels are located. So our two main approach is the radial approach and the femoral approach. When we do our procedure, you have to take care, because I mean, from start to finish, if you don't take care, then you're going to run into complications, and complications are always not good. So to get your vascular access, whether it's the radial or the femoral, we use what we call the modified Seldinger's technique. That is, you see, we have a needle, because we have to cannulate, we have to puncture the artery. So we have our needle, and we don't want to go through the blood vessel. We want to stay in the lumen of the blood vessel. So we take our needle and we gently puncture the blood vessel. Because it's a artery, blood is going to spew back on you. So you're going to get blood spewing back. And that's the difference between your artery and your vein. Because the artery is under pressure, blood is going to gush back at you. So you know you're in the artery. And it will be bright red blood usually. So once you're in the blood vessel now, you get what we call your guide wire, and you advance. So you keep your needle in position, you advance the guide wire into the vessel. So this is a wire that is not very stiff, and it shouldn't puncture the vessel, and it will run into the lumen of the blood vessel. Okay? Now you can remove your needle, because the needle is sharp. It will traumatize the artery. So you remove the needle. Okay? You have your guide wire in place, and then you put what we call a sheet. So this is a plastic tubing that you put over the wire, and this is what. So the plastic sheet comes with an introducer, because without the introducer, the sheet is going to be too flimsy. So you position your sheet with your introducer into the blood vessel. Then you remove the introducer, which is a stiff plastic tubing. You remove that, and then you leave just the sheet in place. The sheet is, not very stiff, and it stays in place, so you can access the artery from time to time. Okay, and then you can put you can we usually connect this up to your manifold that will record pressure. You have side arms where you can remove blood and add medications, fluids, etc. But this is what you leave in place, the so-called modified Seldinger's technique. Now, we usually use certain type of catheters to do our procedure, and we talk about our left Judkins catheter or right Judkins catheter, and your left Judkins catheter looks like this. Okay, it looks like this, and we have different curvature. For a small individual, we use a 3.5. For an average size individual, we use a JL4. Looks like that. Um, we can use a larger curve because not everybody have the same anatomy. And if the patient has a very dilated aortic arch, you want to use a larger curvature. And when you do the procedure, you will know, okay? And but a lot of people will start with your JL4 because most average individual will accommodate a JL4. But once you start doing the procedure, you'll see if it's a small aortic arch, use a 3.5. If it's a larger aortic arch, you might use 4.5, 5, and even sometimes 6. And then you have your JR. So JL stands for left. So it's your left Judgkin catheter. You use this to cannulate your left main. You use it to cannulate your left main, and then your JR, right Judgkin catheter, you use that to cannulate the right coronary artery. And then you have your ALs as well. So you also have pigtail, and these are what we call pigtail catheters. These are catheters that we use to do left ventriculography. That is, we position these catheters into the left ventricle, and we can do, we can see how well the heart is pumping once we inject dye. And the reason why they're curved, pigtail catheters, is because we're entering into the left ventricle. We don't want to use a straight catheter because the straight catheter can puncture the muscle. It can puncture the myocardium, and I have seen uh, complications where I'm not sure if they use a straight catheter, but I've seen complication where the left ventricle muscle was perforated, and when they did the LV gram, you can see the dye going into the pericardium, and that was a mess. So you want to use a curved catheter. You want to position your catheter in such a way that you don't get trauma to your muscle. So you position that in your left ventricle. All right. So when you do your radial approach, say you cannulate, you use your vascular access is the right radial artery. So remember, your catheter is going to come up the radial artery, then brachial artery, then the subclavian, and then you enter the aortic, the ascending aorta. So when your catheter is going to come down the ascending aorta, and then you can cannulate. So this over here is your left main, right coronary artery is right over there. So all you do, you just position the catheter into the vessel, So what I normally use if I'm gonna cannulate the left main, uh, I'll use a left Judgkin catheter, usually at 3.5. Uh, because I'm now doing radial. For the radials, I'll use a little smaller curve. So I use a 3.5 left Judgkin catheter, and sometimes you have a little problem getting your catheter over, getting it over this little bend and getting it into the ascending aorta. But with practice, you can get this fairly quickly. And then you cannulate your left main, you inject dye and get pictures. And then for the right coronary artery, you use your right Judgkin catheter and cannulate the right coronary artery, inject dye. If you're using your left radial, then you have to know the anatomy. When you come to your left subclavian, then you're going to enter the aorta at this point, and you want to come over this way to cannulate. So you want to get across the aortic arch, the ascending aorta, and then you cannulate your blood vessels. Left main is over there, right coronary artery is right there. For the femoral approach, remember now you're coming up the aorta. You're coming up the aorta. You're going to come to your descending aorta. You're going to go over the aortic arch, the ascending aorta, and then you approach the blood vessels. Okay, so you can cannulate your left main, okay, and then your right coronary artery. Again, I commonly use for left for the left cannulate the left main. I'd use a JL4 if I'm doing the femoral approach. That's a left Judgkin catheter, curvature 4. Okay, and you cannulate your blood vessel. All right, so let's what we're going to do. Uh, I'm going to show you a actual procedure that I did and walk you through the steps. Okay. All right. So again, so in the cath lab, you have an assistant. So your assistant is gonna, you know, assistant should be able to follow the step closely. I mean, a lot of time you don't say anything to the system because they know exactly what you're doing and they know what to give you um, from time to time. They're following the procedure closely. If there's anything going wrong, they'll also alert you. So you have your assistant, you have a nurse, a floating nurse. So if you need any medications, you need anything, you'd also have a floating technician that will help to get you whatever catheter you need, whatever else. And then you have another technician who's monitoring. So this is the cath lab room where we gonna use our ionize and radiation. So everybody in this room needs to have a lead protective wear on. So you have your lead protective wear on. Um, and we talk not only we use a lead protective wear to cover the front and sometimes the back, or sometimes it goes all the way around. And then you have what we call a thyroid shield. So this is to cover the thyroid and protect. So you have a thyroid shield. Um, so these are the individuals in the room. So you will have three persons in addition to the operator in the room. And then outside the room, you have another technician that uh, is a monitor that they whatever medication you're using, they put that in the computer. They're recording what you're doing, um, in a timely fashion. So the patient is on the table. This is the camera above the patient for you to visualize and see what you're doing inside the patient. Um, so before you uh, get access, you have to numb the area. Okay, so you numb the area, make sure that the patient's not gonna have any pain. You numb the area. Then, as I showed you, the modified Selzinger's technique, you use that. Okay, so we're numbing the area. So this is a femoral approach. So you have to feel for. Remember, when the artery is pulsating, so you can feel for it, and you'll know you can locate it. Then you want to give your anesthetic. You don't want to put your anesthetic into the artery. Okay, your anesthetic should be around, not in the artery. Okay. So you you give your anesthetic into the area. You want to numb the area because you're going to be working there. You're going to be using needles and stuff like that. So you want to numb the area. So it's a little bit. So that's our needle right there. It's a little bigger patient. So that's why I put a syringe. So when I'm gonna enter the blood vessel, but I'm gonna pull back, and that will tell me when I'm in the artery. I don't want to go through the wall. So, if it was a smaller patient, I would not have a syringe on the needle, and I can see the blood flowing backwards. But it's a little larger patient, so I'm palpating for the artery. So you feel for the artery, and then you at an angle, you go in and you pull back as you go in. Once you hit the vessel, you see blood comes. So bright red blood come back. I take off the syringe and the blood. So it's an artery, so the blood is coming backwards. So that's my guide wire right there. So you insert your guide wire into the blood vessel, as we showed before, into the blood vessel. You remove the needle now. So the wire is going in. Then you you look. So it's always good to look to make sure you're in the you're in the lumen of the blood vessel. Then if you encounter any resistance, you pull back and then you can go again, and you shouldn't have any resistance. Okay. All right. So you always so that's our wire. So it's a femoral approach. So the wire comes up the aorta, the descending aorta, and the wire is going to go over the aortic arch, and you're going to go into the ascending aorta. All right. So you're in. So you're in your. So this is our guide wire because. So you want to go up with a wire because you don't want to traumatize the blood vessel. So over that wire now I'm going to put my catheter. So I'm going to cannulate the right first. So I'll use the right Judkins catheter. Okay, so this is our side port. You always pull back, so you always pull back and you remove some blood because there are going to be clots in the system. You don't want to inject clot in the patient, so you remove blood that's in the system, and then you can. So you always do your procedure with guide wires. So guide wires, and then your catheter go over the wire. So this is our monitor. So the camera is over the patient. The monitor is right there, so you can see what you're doing. Okay. And so that the second approach is we use the Judkins catheter, Judkins left. So use our Judkins left, and then we cannulate the left main, and we inject dye. So okay, so that's the right. Sorry. So this is the right. So we use our our right Judkins catheter. We go over the aortic arch. We go to the right cusp, and we cannulate the right coronary artery, inject dye, and then you take pictures. So that's a right coronary artery, and we make sure that we're looking for obstruction, any obstruction. And so we'll take multiple views. So we'll do multiple views. Okay, so you want multiple views. So okay. So again, we load our catheter over the wire. So you use the camera to follow your progress, see what you're doing. And this is our pigtail. We're going to do an LV gram. So this is our pigtail. We're going to enter the left ventricle. Sorry, that was our left Judkins catheter. So that's our left Judkins catheter. And we're going to cannulate the left main. So you have to look, see what you're doing. So the shape of this curve, it's the left Judkins catheter. We cannulate the left main coronary artery. Okay, and you can see when you enter the blood vessel, you see jump. You can actually jump into the left main. You get a little injection. So this is the left main right there, and then we can. So, and then we inject our dye. So we inject our dye to look at the blood vessel in its entirety. So, so, so this is our left main coronary artery, and if you remember your anatomy, the left anterior descending coronary artery is going to come right down here. Left circumflex is going to be over there. So this is it's a LAO cranial shot. Okay, so the left main LAD circumflex is over there. So okay, so you can see. So left main LAD with its branches and then left circumflex. Okay, so this is our left Judkins cath. So you're going to take multiple views. Okay, so this is, I think, it's an RAO view. So your left main is now going to come down here. This is the left main. And then the circumflex is going to come off like that. So it's a RAO view. So this gives you, so it's an RAO, right anterior oblique, and it tells you caudal or cranial. So okay, so we take another picture. So because this is an RAO view, your left main is right there. The left anterior descending coronary artery comes down here, and your left circumflex is right there. So depends on the view, your vessel gonna be in different. You're gonna have different orientation of the blood vessel. So that is our RAO view. Okay. Now another view of the left main and its branches. That's an RAO caudal view. So that's another view. And this is the monitor showing your waveforms. So this is the catheter is in the aorta, and you can see the waveform. You want to make sure that the waveform is what you expect, and the pressure is good. So this is the that was then um, I don't think we have one with the left ventriculography, but we use the same approach. Um, we're gonna we're gonna stop here, and the next series of sessions we're gonna look at the complications, and then we're gonna look at actual angiograms. Um, we're going to look at some normal angiograms first, and then we're going to look at some angiograms with obstructive disease, and then we look at some intervention, balloon, angioplasty, and stenting. All right, so in the interest of time, we're going to stop